Hi everyone, my name is Dr. Riya Thakur and I am from Medit Trainers team. Welcome to today's webinar. So today we are very excited to discuss a very important topic that has been overdue for a very long time. That is simplifying the implant workflow with the Medit intraoral scanners. So for this special topic, we have a special guest with us, that is Dr. Priya Maditya, who is also our key opinion leader and the speaker for today's webinar. So to give you a quick introduction of Dr. Priya, he is a prosthodontist and a German certified implantologist. He runs his own clinic in Pune, which is uniquely equipped with an intraoral scanner, 3D printers, and implant planning softwares. So his practice is truly a pioneer in digital dentistry in the Pune city. Dr. Priyam has a deep passion towards digital dentistry as well. He has presented many numerous papers on his name and won several awards and several awards. Also, he lectures internationally as well as nationally. And the topics are mainly like surgical guides, implants, 3D printers, and intraoral scanners. Additionally, the main thing, he also serves as the president of Pune branch of the Indian Prosthodontic Society. So this was a quick introduction of our speaker, Dr. Priyam Aditya. So Dr. Priyam, we are very honored to have you here today, and we all want to learn as much as possible from you today. Okay. So yes, we have got you.
Finally it's working. This is actually a good sign that there's some technical difficulty. It means whatever difficulty we had is now over and we'll have everything very smooth now. So thank you for the introduction, Dr. Ria. And I am a Medit fan. I accept this openly. It's a great scanner and I'm very happy to be speaking about it today. Without wasting any time, I think we can quickly move on to the presentation and maybe we can do all the discussions post the presentation.
Okay. Thank you, Dr. Priyam.
Greetings from India. I am Dr. Priya Maditya and I'm a prosthodontist by training. And today I'm going to talk about how Medit is simplifying my implant workflows from last 2 to 3 years. Medit, when I started with Medit, I was using i500. The technology improved and we got the new i700, which most of us are using now. And of course, the future is already looking at us. i900, which is a fabulous piece of equipment, is already there in the market and getting launched zone by zone or country by country. A little about me. I come from a city called as Pune, which is in the western part of India. And currently we are having a monsoon season in India, which is a beautiful time to be in Pune. So if you ever come in, please do drop and meet me. And I like to click whatever I see. And in a world where I see everything in micro, I try to make it macro. And I click whatever I see around me, which might be something which we miss on everyday basis. Things which crawl around us, things just fly around us, but they are beautiful when you capture them. But I'm a dentist and I have to keep all my eyes open. And when I say all, you can already see I've got 4 eyes. So I have to keep my 4 eyes open so that I can see what is happening around me. When we jumped into the world of digital dentistry, we also jumped into the world of 3D printing. We do a lot of 3D printing, guided surgeries, digital dentures, but the journey starts in every case from a scan only. So our intraoral scanner, a good Medit intraoral scanner is the first stepping stone into the world of digital dentistry, and I would strongly recommend them from my side. Anything in my clinic is of course possible with the help of my team, which is always there to support me. They are also well versed with the 3D printing and the intraoral scanning and how the digital workflow works. We also have a company called as D3MD, which basically is into dental designing space where we do guide fabrications also. But coming back to the topic of the day, why to use iOS? I get a lot of calls from doctors asking, should we buy an intraoral scanner? Should we not buy an intraoral scanner? And unfortunately, in most of the cases, the reason why they are buying intraoral scanner is FOMO. They are thinking that probably the one who's next to me is buying, so I should also buy it. And then they just buy anything in a hurry because they don't know what to buy, or they don't have the time to analyze, because they are not doing a purchase based on the logic of turning into digital dentist, but on the fear of missing out things. Friends, that's not the way to go forward. And before you buy anything, and that to an equipment which some people will call it as expensive, you should understand what you're buying. The four terms that you should understand is distortion, precision, trueness, and accuracy. If you understand these four terms, just even a basic of it, you'll be able to compare the scanners, you'll be able to make a right choice for yourself. Distortion is, as the word in English would mean, it is basically a relative or absolute motion of point or group of points with respect to one or more reference point. Leaving the definition in simple terms, if there is a point of reference and there is more point of references to it, how much they change from each other when you are actually recording it in an intraoral scanner. Now, this distortion can be on the outer surfaces of the STL file, or it can be the STL file also, and that's decide whether it's a external distortion or an internal distortion. But this distortion will obviously going to modify or alter the data that you've recorded, and hence a good scanner is the one which records with minimum distortion. Precision is a word which the salespeople use a lot. They will say our scanner is more precise. Precision is that if you have a point A and a point B, and a distance between them is, let's say, 1 millimeter, if I scan 100 times the same area, every time it should ideally come out to be 1 millimeter, because actually the distance is 1 millimeter. But that is not true, unfortunately. So whatever or whichever scanner can do that more number of times and with more accuracy is more precise, to be in simple terms. And similarly comes the word trueness. Trueness does not just means that your tooth should look like a tooth on a scanner and should not look like an animated printing of your teeth. Uh, Trueness means how accurately or how in much in real dimension can you represent the measured structure every single time. And if you're able to understand accuracy, precision, and trueness, that's exactly what you're talking about when you're saying it's more accurate. So these are the points that you have to basically understand when you're comparing scanners. Speed is also one thing which people want to look at, and they do compare a lot on speed. In fact, there's a lot of buzz around the speed. But speed is something that will make you go faster, will definitely help you in better scans, I believe. But I believe these points are more important than just the speed of the scanner. So coming back to why use iOS and not just because of FOMO. The advantage is that now you can make digital impressions which you can record even in multiple appointments, not just in one appointment. So if the patient is very uncomfortable, you can make a lower scan and not do the upper scan, or even you can do a part of scan, and let's say that the prep was bleeding, you can stop and you can then continue from the next time. So it is a very convenient way of doing that. Unlike how in impressions, once you mix a material, let's say an A-silicon or even if an alginate you're talking about, you are on a timer and you have to finish the procedure in that time only. Even if the patient is not comfortable at that point of time, you might have to sometime push the impression. No messy materials. This is something that your patients will love. Your staff will love it even more. No messy materials, no gagging patients, no dripping saliva on you. It's super comfortable for your patients, and the secret is it is super comfortable for us also. You can make 3D models, you can make restorations immediately on your computer, and then you can mill it or print it as what you want to do, and that all with a very high accuracy. You can have an in-house milling, you can have an in-house 3D printing. You can also send all this to your lab just by a click of a button, and they can do the same thing for you and send it back to your practice. There is maximum hygiene, there is low cross-contamination because you're using now less equipments which can be autoclaved, unlike your rubber bowl in which you're mixing alginate or your silicons. It's time saving. As I said to you, it's very, very easy just to share your data with your lab. Just by using Medit link, you can share the link, you can share it via WhatsApp, or you can use an email and send the link. If you're a person who would like to export the data and then send it in in an email, you can do that as well, but it's pretty quick. You don't have to wait for somebody to come and pick up the material, the impressions, and you don't have the risk of the material getting distorted. That's a big plus for an intraoral scanner. COVID times have been disturbing in all over the world, all over the countries, and patients are now very aware of infections and cross contaminations. Especially in older patients, sometimes the patients do not want to come many times because they feel that they're getting more exposed and have a higher chance of getting any kind of infection. So in those patients, you can scan and you can sometimes reduce the treatment time for them. Especially if you're doing dentures for your old patients, you can actually keep a scanned copy of your dentures. And if the patient happens to break the denture, you can just duplicate that denture and print a denture and send it back to them at their homes without them coming to your clinic. So that's a big plus for an intraoral scanner. And of course, you can plan your surgical procedures, you can do guided surgeries with very high precision, and you can give your prosthesis on the same day itself. So let's understand basic workflow of a digital dentist in a clinic, especially when you are using intraoral scanners. What we do is we scan the jaw, we review the scan. Always review a scan. In fact, one tip from my side would be to always invert the scan. If you invert the scan and if you see any holes anywhere, you have to go and rescan that area. So then we review the scan data and we send it to the lab. The lab will fabricate a prosthesis depending upon what kind of work we have ordered. The prosthesis will be milled or printed and it will be finished and then it will come back to our practices. So this is a very basic workflow that will happen when you have an intraoral scanner. When I was preparing this webinar, I was thinking what would be the best way to show how much I have changed my workflow. So I digged up a case which I had done almost 10 odd years back, and I'm sharing that with you. So this was a case where we had done a fixture level impression and a simple problem, and please understand it's a very important point that I'm making. A simple problem in an impression making is that you have a discrepancy between the healing abutment diameter and the diameter of the impression post, whether you're doing a closed or an open impression post. So for example, you put a 3.5 millimeter implant and you have a small healing abutment. You place it, you get the profile of a small healing abutment. You place a 4 millimeter implant in a premolar. Now, the implant is just 0.5 millimeter bigger, but you might want to put a 5 millimeter healing abutment because you want a better profile over there, because probably the premolar was broad. And same thing will happen if you're doing a 4.5 millimeter implant. The prosthetic components remain the same, which means the channel or the diameter of the channel in which the components are fitting is the same. It is the top part of the healing abutments which is changing to give you the profile as what you need. So if it's a molar, maybe you're using a 7 millimeter diameter healing abutment. Now that's a big change that you're doing. So if I have the implant in which I had placed, let's say a 5 millimeter healing abutment, and I put my impression post on it, now if I measure, the impression post might be of a similar size of a small healing abutment, but it might not be of a size matching to that of a medium healing abutment. Now, whatever gap is there around that tissue, where between the impression post and the healing abutment is there, that gap is something which will collapse as when you are trying to make the impression, because the tissue will immediately start to collapse. Also, if you see the same thing in cross section, a 4.5 millimeter implant, a 4 millimeter implant, a 3.5 millimeter implant, the internal channel or the diameter of the internal channel is same. So if you put an impression post or a open trail impression post or a closed impression trail post, whatever is the gap between the tissue periphery and the impression post will collapse if you don't do anything. And you cannot just record this in material immediately because impression will take some time. To encounter or to counter this problem, what we did in those times we were using customized impression post. So we were using customized impression post for molars especially, and we used to use composites to customize the impression post every single time. then make the impressions. We used to make custom impression trays. Then we used to put the retraction cord, remove the healing abutment, put the impression post. You can see a little bit of blanching around the impression post that we have just put. That's because by the time we removed everything, settled everything, and put the impression post back, the tissue had already started to collapse. Once this is done, we ensure that the post is sitting properly by making an X-ray, and we check that the impression post is properly seen through the open impression tray that we are going to do. And then we used to make the impression. And that's how we used to capture it in our practices about 10 years back. So that's how the lab would send us the work back using models which is made in stone with the gingival masks. The crowns would come back. Again, on the day of the placement, we would remove the healing abutment, check the health, and then place everything back, try. We still use a cement screw retain combination type of prosthesis. So excess cement, what you can see over here, of course, we have used a lot more over here just to show it in the pictures. We used to remove all the excess cement from everywhere, and that's how we used to finish the case. So that's an occlusion, and that's the post-op X-ray. So this is how much we had to work when we were doing a single implant at that point of time. But with the intraoral scanners, the work is pretty easy for us now. Now what we do is, this is a case which is an older lady, 70 plus. She came, she was having a bridge from almost 10 years, which unfortunately for her broke. Now she's a lady who's scared of more surgeries, even though she has got a lot of implants done in her mouth, but she doesn't want any extensive surgeries, no graftings is what she wants. So we did a guided surgery, we did a guided planning for which we had to use an intraoral scanner to scan. We shifted the data to the planning software with the data of the CBCT and the data from the intraoral scanner. We stitched everything together, and from there we fabricated the guide that you can see on your screens. Post that, we autoclave the guide, we place in the mouth, we go ahead and do the surgery. So you can see on the screen, the first is the pre-op, then second image is the tissue punch, the third is the implant placed, and fourth is the healing abutment. And what I want you to note is that the healing abutments are of different sizes. So that's the immediate post-op radiograph, and that is when the healing is done. Now you can see that the emergence profile for one implant is different from the other implant, which means I will have to do 2 customized impression posts, and then only we can go ahead with this. But with the intraoral scanner, things are easy. All we did was we simply scanned everything. So we did an initial scan. After doing the initial scan, we simply punch out the area where the healing abutment was, and we remove the healing abutment, and we come back and capture the same area again. So in one shot, we have just captured 2 different kind of emergence profiles. And also, if you see on the scan, we have captured the tooth preps also. So we are able to capture the implant position with the help of the scan bodies. And all this is done in just one step in maybe 15-20 minutes, nothing more than that. And it's super comfortable for the patient and equally comfortable for us. So no making a custom impression post, no worrying about the gingiva collapsing. Everything just happens very fast. So we did use something called as bi-HPP abutments. We fabricated the prosthesis. So those are the 4 individual crowns which were fabricated, and that's how they were in the mouth. So from an old bridge which broke to a pre-op condition where there was nothing in the center to having 4 single crowns, the journey is comfortable because it's a digital journey starting with an intraoral scanner. So advantages of intraoral scanner in this particular case was that there were no messy impressions, especially in perio patients, older patients where there's a lot of intra-dental spaces. You do tend to get material over there which locks, or sometimes it's very uncomfortable for us to remove the tray and say so for the patient. So there's no messy impressions. There is no problem in managing the micro movements of the tooth versus the implant because implant has no micro movements. You can capture varying emergence profile, even if you develop a custom profile for a, let's say, a maxillary anterior or a lateral or a canine, you can capture those custom profiles also without any hassle. You can simply just send a link to the lab and the data gets transferred immediately. And most important of all, your patient is super comfortable. So this is how we are working now. But when we talk about scan, there has to be some reference point, there has to be some basic properties that has to be there in a good scan to say it's a good or acceptable scan for the work. Not every scan can be a good scan. So when I started searching what is a good scan, what I did was I searched on Google and I wrote, what is a good intraoral scan? Unfortunately, the pages were filled with company promotions to people talking about different comparison of scanners, individual promotions. And I went to the next page, which is a big thing to go on a next page in Google search, but I did that also. And everywhere, everybody was comparing brands to their experiences, but nobody was talking about what is a good scan. I need to know as a beginner that this is a good scan and I can send it to the lab for the work to proceed. So what I thought was like, let's go back to basics then, because in basics, we know what is a good impression. I'm not talking all the points here, but I'm just taking few of the book. It should cover all the surfaces of the teeth, including occlusal surfaces. It should extend to the mucobuccal fold or sulcus. In maxilla, it should cover the entire maxilla, including the palate. The impression should be free of any pulse, any voids, any air bubbles. The preparation should be clearly seen. The margin should be clearly seen and identified without any contamination on it, no blood, no saliva on it. And the material should flow zero point 0.5 millimeter beyond the margins so that you can identify the margin or the technician can identify the margin in the cast. Taking from the same points, I thought of building my own so-called criteria for a good scan. Let's see how it goes. A good scan should cover all teeth surfaces, including the occlusal surfaces and interproximal surfaces. It should extend to the sulcus or the mucobuccal fold, or at least cover 5 millimeters beyond the margins. Whether it's an emergence profile margin or your tooth preparation margin, you should cover at least 5 millimeters beyond the margin so that you can develop the emergence profile in the prosthesis. In a maxilla scan, palate, many times we don't take it for crown and bridge, but if you're looking into implants, you should cover palate. Sometimes we do superimpose data just by using palettes as the reference point, especially if you are doing pre-ops and you're merging with the preps, palette is the reference point and nowhere else. So do cover your palettes if you're using pre-ops, wax-ups, or if you're doing maxilla implant work, do cover palettes. An extra bit of data doesn't harm you. You never know it's going to be helpful to you. There should be no voids or areas of data missing. That's very, very important. We should not ignore a data which is not in the area of our interest and just say it's not needed. We should cover everything properly. There should be no double layers of data in the scan. Now, this is a very common problem when you are doing edentulous scan, and maybe someday we can talk about edentulous scans also. But today we are talking about double layers in single implants or double implants. So make sure there are no double layers in the data. There should be no step in the continuous surfaces of the data in the scan. For example, if you follow the company protocols, it is asking you to scan from one end to the other end. But if you start from one end and you jump to the other side and try to meet in the middle, sometimes you will get a step in the central incisor area. So all these things should be avoided and can be very easily avoided if you just follow the protocols recommended by the company. The emergence profile of the implants or the prepared margin should be clearly seen without any blood, saliva, or any other contamination on it. The scan body should be completely captured or matched with the AI help. And I'm going to just stress on this point that when you're using AI to match your scan body, please be very careful that you're picking up the right scan bodies. The companies keep changing the scan body design. They keep coming with new scan bodies. So ensure whatever scan body you have is the one in the system also. Otherwise, a small change can be missed and that will lead to a big change in the implant position. But having said these points, and I'm somehow boasting only about scanners, does the entire responsibility lie with the scanners only? Does it mean that if I give a very, very good scanner to a beginner, he or she will get me a fabulous scan? Not true. You need to perfect your scanning techniques. In the beginning, you can see and follow the scanning techniques which are recommended by the company. it blinks on the side. You can actually follow it and do it. And once you master the recommended techniques, you might take some shortcuts. You might develop your own techniques and share it with us, which might be even better than what the company is doing. But in the beginning, follow the techniques that the company is recommending. It definitely helps in recording a better scan. So let's see again how a simple implant flow work will happen with the help of intraoral scanners. So what we will do in my practice is we will first scan the entire arch, and I'm only talking about the working arch, not any other arch. And then we will scan with the healing abutment on. We will lock the neighboring areas, and then we will delete the area where the healing abutment is. After that, we are going to immediately scan the emergence profile so that we don't lose any of the emergence profile. Post that, we are going to record the scan body. So we will put the scan body first, and we will make sure that we don't use any prosthetic screw to put the scan body. So place the scan body without the prosthetic screw. Make sure that it is fitting properly. You can also rotate it slightly to ensure that it is fitting or not. So just give a little turn to make sure it's sitting. And once you're 100% sure that your scan body is sitting without any problem, then you can use the prosthetic screw and tighten it. Once that is done and once you have confirmed, you can now do the second scan, which is the scan body scan. And then you can go ahead and scan the opposing arch, or you can do it before that also, and then you can record the bite. While recording the bite, the scan body can be removed and then you can record the bite so that there is no interference of the scan body with the opposing arch. So coming to a case, exactly how we are going to do this. So this is a case where patient has got her 1.5 and 1.7 extracted a few years back, and now she wants a replacement, and you can see the bone levels when it comes to 1.7 and 1.5 on your screen. So what we did was we did an intraoral scan, we did a digital planning, and in the digital planning, we were able to see what we are going to do with the patient. We fabricated a guide, we placed the guide in the mouth, and we did a surgery for her. Once the surgery is done and the implants have integrated or healed, we put the healing abutment, and at 3 months, we recorded the shade and we recorded the implant positions. So you can see over here, we are recording the maxillary arch. We are making sure that we record everything from the opposing side to the same side. And we do record the emergence profile now, along with the tooth which is prepared. If you can see the data which is not getting captured is because we have locked that data. We don't want that area to be captured again and again because that can lead to a distortion. And once the emergence profile is recorded, we will go ahead and then we will record the implant position using the scan bodies. And whenever you're recording the implant positions using the scan bodies, please ensure that you capture a longer area so that the softwares can merge the two data better and don't just capture a small area of scan body itself. Then this work is sent to the lab selects the abutments, the crowns come back, and we place them in the mouth. That's the post-op. So that is how we are now doing the digital workflows for simple implants, which is very easy, very convenient, and very fast. Coming back to some basic scanning errors in implantology. There can be steps in the scan. Usually, if you're capturing from right to left, especially if the implants are on both the sides, please ensure that there are no steps or no jumps in the implant in the scanning. Otherwise, the implant positions or relative implant positions will change to each other. Double scans in same areas, especially in the sulcus areas, or if you're doing an area like 4.7, 3.7, when sometimes the correctness because is very less, maybe a millimeter or two, it is very easy for us to capture double scan. So my suggestion is to use a retraction device like Optra Gate. Or what I do is I use a blue glove and I put my full arch retractor inside and then make sure that the position of the tissue is maintained throughout the scan. This really helps me, especially when we do full arch scans. So you can see over here, there is a double data captured in the same area because the mucobuccal fold moved. So we have to ensure that this never happens. Emergence profile not recorded well because of bleeding or some other issue. Emergence profile has changed by the time you have recorded it. So you remove the healing abutment while you are scanning everything else, and by the time you come back to the area of interest, the mucosa can collapse. Scan body not properly oriented to the implant. Sometimes not, sometimes there's a wrong selection of this scan body also. So please ensure that your staff is putting a right scan body for you on the tray and you place it properly. Scan body not captured well. Sometimes we do not capture the scan body's distolingual or a distobuccal line angles, or sometimes mesolingual line angles are also very difficult to capture in scan body. Please ensure that you increase the depth of the scanner, but you capture it well. Again, wrong scan body should not be used, and wrong matching definitely is not something that is preferred. You have to avoid it anyhow. Holes in the data not recorded in the proximal areas, especially in future contact areas. As I told you in the beginning, if you are scanning, always flip the scan and search for any holes in the scan. Errors in correlating two or more scan bodies can also be a problem. So do follow the recommended protocols for scanning and using outdated or old scan bodies. When you're doing an abutment level scan, please ensure that the margins can be identified well. Inaccurate bite registrations can also lead to a problem in your implant prosthesis. And distal extension cases is still sometimes a little bit of problem, especially for a beginner. So at times, a verification bite is necessary or is helpful to your lab to do the needful. How would you capture two or more scan bodies? The simple trick is to capture one scan body, log that area, and then do the second scan body. Always use a neighboring structure, tooth structure, to as a reference point, and from that reference point, try to correlate the scan bodies. This is the best and the easiest way to record scan bodies in simple cases. So you can correlate one scan body to one tooth, one scan body to the other tooth, and then you can correlate the two scan bodies to each other with ease. You can also use the log function. That also helps a lot, which is a very good function in Medit app, so that you don't go over the same data again and again and distort it. And if you follow the right techniques, you will be very easily able to do not just single or double implants, you'll be very easily able to do full arches also. And I'm particularly showing you a mandibular arch scans here because they are notorious for getting recorded with the intraoral scanners. But if you follow the right techniques, it is possible for you to record them without distortion. And these are completed cases. We have done verifications. Scanning was not a problem at all in these cases. And of course, you can record for the both maxilla mandible also. Maxilla is a little easier as compared to mandible, but with the right protocol, I think both should be easy for you. Of course, it requires a little bit of practice at our ends. So what is my take-home message for all of you? The key factors for a successful scan is adequate soft tissue management. And this is very, very important. I cannot stress enough on this, but this is very, very important. Please understand that as an individual, as a human, we can understand that this is gums, this is teeth. The softwares, the AI is catching up, and they are also able to recognize a lot of things, but a human eye is still beating AI as of now. So when you are scanning, please understand that the scanner also needs your help. If you keep moving the tissues, the scanner will not be able to correlate them, and hence you will have problem. Similarly, bleeding gums, bleeding emergence profiles are also a problem because the scanner cannot capture blood. A small drop of blood, a small drop of fluid on gingiva or margins will or might get recorded by the scanner, and that will lead to a distortion in the margin, which is not there. That will lead to open crowns, and that is not something that we can put on a scanner. We have to use proper light and contrast conditions. Sufficient overlap of scanning images are needed so that the software can stitch the images better. Always calibrate your scanner when the software is telling you to scan. Calibration is very important. The newer scanners, the i900 would not require will not require a calibration every 14 days. So the company has done major developments when it came to i900, but calibration is very, very important. And of course, infection control, that's very basic when it goes to dentistry, that there should not be any cross contamination. There is ever improving technology. I started with the i900, then came i700, i500, sorry, and now i900 is there, and it's a beautiful piece of equipment. I was lucky enough to get my hands on them to use and document few cases. But trust me, it's a software, it's a scanner which is miles ahead of the others. It's got 3 tips. It's wonderful. I mean, the company will give you more information on that, but I'm thrilled to have such a scanner coming from Medit. And of course, we use a lot of Medit Link because it makes our data safe. Most importantly, we have all the data saved with us, and wherever we are, doesn't matter whether I'm in practice or not, I can always open a scan and show it to somebody how it's to be done. The data is saved, and at the same time, the Medit Link allows you to share the data with different labs with just a click. You can directly send it through the software, or you can send it through copying the URL, and then you can send it through WhatsApp or emails or whatever way you like. But that's a very big advantage when you use Medit-Link. Of course, there are numerous apps to support you, and I'm in love with those apps. Especially the Model Builder app is, I believe, one of the best apps that any software has. And apart from that, the occlusal analyzer is there, which is also very accurate. You can use the auto stimulations, the smile designers, and there are numerous features. I mean, that's not my job to talk about today. So make best of your Medit link. Don't just see it as a scanner, see it as an entire ecosystem, and make best of your ecosystem. If you have any questions and answers, we can always discuss those in detail. And if you want to reach me, these are my details. My name is Dr. Priyam Aditya. I am practicing in Pune in India, and you can always connect with me on Facebook, Instagram, or you can follow our YouTube channel, which we have just started to build. Thank you very much for your time, and thank you to the Medit team for organizing this webinar for us. And it was lovely talking to you guys. Thank you.
Hey everyone. Okay. So, Dr. Priyam, it was really a great presentation, and you have covered a lot of details, as well as I really like the part about the lock screen tool that you had covered in it. So today we are ending the session. Thank you, Dr. Priyam, for all the details that you have shared. And the webinar was wonderful.
Thank you very much.
Yes. Okay, everyone. We will see you for the next time. Bye bye.